Welcome to Roadmap to Residency, Evidence-Based Applications. And in this video, we will be talking about some of the immune system disorders. We will be reviewing the first aid part first, and then we will solve some questions from the topics that are very frequently tested in the examination. So, talking about immune deficiencies, let's just start with X-linked or Bruton A gamma globulinemia. So it is a defect in the BTK or tyrosine kinase gene or BTK gene. So there is no B cell maturation. It is X-linked recessive, so it occurs more in the boys. So remember B for B. There's recurrent bacterial and enteroviral infections after the age of 6 months because there is decrease in the maternal P from IgG antibodies. The absent B cells in peripheral blood, there is decreased immunoglobulin of all classes. The absent or scanty lymph nodes and tonsils. Live vaccines are contraindicated in case of X-linked Bruton A gamma globulinemia. The questions of X-linked Bruton A gamma globulinemia, generally you need to remember that in the child, the tonsils are absent, okay? The tonsils are absent, and also the question will give you a history about the maternal uncle or the uncle of the child, okay? Or the uncle of the child is dead, okay? Or the similar symptoms of the similar symptoms in the uncle of the child. So uncle absent, tonsil absent, X-linked Bruton A gamma globulinemia, the buzzwords. The selective IgG deficiency, the cause is unknown, and is the most common primary immunodeficiency. It is majoritarily asymptomatic. We can see airway and GI infections. It is autoimmune disease, causes atopy and anaphylaxis to IgA in blood products. That's why you need to give blood products with vast RBCs, okay, vast RBCs in the patients of selective IgA deficiency. There is decreased IgA with normal of other antibodies, and there is increased susceptibility to giardiasis in these patients. Talking about common variable immunodeficiency, there is defect in the B cell differentiation and the cause is unknown in most cases. It may present in childhood, but usually diagnosed after puberty. There is increased risk of autoimmune disease, bronchiectasis, lymphoma, and sinopulmonary infections. There is decreased plasma cells and there is decreased immunoglobulins. Talking about the T cell disorders. So let's first talk about thymic aplasia. So the thymic aplasia, also called as the disorder syndrome, is due to the 22q11 microdeletion, and there is failure to develop third and fourth pharyngeal pouches. There is absent thymus and absent parathyroids. So since there is absent thymus, there is decreased T cells, and since there is absent parathyroids, there is decreased PTH. And if there is decreased parathyroid hormone, the patient will suffer from hypocalcemia, right? So there will be cardiac defects. That's why it is called as the velocardial facial syndrome, because of the defect in the palate, facial, and cardiac defects. The thymic hypoplasia will lead to T cell deficiency, leading to recurrent viral and fungal infections. There is cleft palate and hypocalcemia, which can lead to tetany. And on chest X-ray, there is absent thymic shadow. Interleukin-2 receptor deficiency due to the decreased Th1 response. It causes disseminated mycobacterial and fungal infections, and there is decreased interferon gamma. The autosomal dominant hyper IgE syndrome, there is deficiency of Th17 cells due to STAT3 mutation. There is cold staphylococcal abscesses, retained baby teeth, and coarse faces. So retained baby teeth and dermatological problems is your buzzword for hyper IgE syndrome. So chronic mucocutaneous candidiasis is due to T cell dysfunction that is impaired cell-mediated immunity against Candida species. This persistent non-invasive Candida albicans infection, and there is absent cutaneous reaction to candidal antigens. Talking about some combined B and T cell disorder, which is called as a severe combined immunodeficiency, is that there are several types, including defective interleukin-2 or gamma chain, and it is X-linked recessive because of the defect in the adenosine deaminase, and it generally occurs in case of children. So there's failure to thrive, chronic diarrhea, thrush, recurrent viral, bacterial, and fungal infections. There is decreased T cell receptor axes and circles. There is absence thymic shadow, and the germinal centers and T cells are also absent. Talking about ataxia telangiectasia, there is defect in the ATM gene, which leads to failure to detect DNA damage, and there is failure to halt progression of cell cycle, which can lead to mutations to accumulate. So it has a triad of ataxia, spider angiomas, and IgA deficiency. Hyper-IgM syndrome is most commonly due to defective CD40 ligand on TS cells, which causes the class switching effect. The thing is that there's normal or increased IgM, which severely decreased IgG or IgA or IgE antibodies. Talking about Wiskott-Adler syndrome, remember water. So Wiskott-Adler causes thrombocytopenia, eczema, and recurrent pyogenic infections. So there is decrease to normal IgG and IgM, and there is increased IgE and IgA. There is defect in the platelet, and there are fewer and smaller platelets. Leukocyte adhesion deficiency type 1, there is defect in the LFA1 integrin protein on phagocytes. So there is impaired migration and chemotaxis. Remember this word, impaired migration and chemotaxis. There is a late separation of umbilical cord, very important buzzword to identify the condition in your examination. There is absent pus and there is dysfunctional neutrophils. In case of celiac syndrome, there is defect in the lysosomal trafficking, and there is progressive neurodegeneration, albinism, and recurrent pyogenic infection. And there are giant granules in the granulocytes and platelets. Generally, they will provide you this histology in the examination. Talking about chronic granulomatous disease, very important. Defect of NADPH oxidase, which causes decreased reactive oxygen species and decreased respiratory burst in neutrophils. There's increased susceptibility to catalase positive organisms, recurrent infections, and granulomas. There is abnormal dihydrorhodamine test, decreased green fluorescence, and nitroblue tetrazolium direduction test fails to turn blue. So here we have one question here with us. So an 18-month-old boy is evaluated for recurrent infections. He has been hospitalized 3 times with pneumonia since the age of 3 months. He has also had multiple skin infections requiring treatment with antibacterial and antifungal agents. Now, during his last episode of pneumonia, he developed a large pleural effusion, which was drained. The pleural fluid revealed numerous neutrophils containing a large number of intact gram-positive cocci. The microorganisms responsible for this patient's recurrent infections most likely produce which of the following virulence factors: catalase, coagulase, lecithinase, lipopolysaccharide, or polysaccharide capsule. So the condition is chronic granulomatous disease. So accident recessive mutation of NADPH oxidase, that is impaired respiratory burst and decreased reactive oxygen species, there is inhibition of phagocytic intracellular killing. So the microbiology, there is catalase positive organisms like Staph aureus, Burkholderia, Serratia, Aspergillus. These are generally associated with CGD. The clinical features are recurrent infections of lungs, skin, liver, and lymph nodes by the above mentioned organisms. There's diffuse granuloma formation, and the diagnosis is by the dihydrorhodamine test or nitroblue tetrazolium testing. So this infant with recurrent pulmonary and skin infections likely has primary immunodeficiency disorder. The presence of a large number of intact bacteria inside the neutrophil suggests CGD. NADPH oxidase resides on the plasma membrane of neutrophils and is incorporated into the membrane of the phagolysosomes during phagocytosis. And it catalyzes the formation of superoxide free radicals. And the neutrophils are unable to destroy the bacteria and fungi through phagocytosis because of the defect in the bursting of the respiratory oxidative burst. A 13-month-old boy is brought to the emergency department due to cough and increased work of breathing. The patient's parents immigrated to the United States when he was 6 months old. He has a history of recurrent otitis media, pneumonia, and thrush, as well as chronic diarrhea and failure to thrive. On physical examination, he is tachypneic and has perioral cyanosis. Chest radiograph shows bilateral interstitial opacities. The patient is admitted to the hospital and undergoes bronchoscopy. Analysis reveals pneumocystis jirovecii. Which of the following is the most likely underlying disease? Agammaglobulinemia, CZD, cystic fibrosis, primary ciliary dyskinesia, severe combined immunodeficiency, and terminal complement deficiency. So severe combined immunodeficiency is when there is gene defect leading to the failure of T cell development, B cell dysfunction, and due to absent T cells. There is accident recessive. It is accident recessive, autosomal recessive. There is recurrent severe viral, fungal, or opportunistic infections causing failure to thrive and chronic diarrhea. The treatment is by the stem cell transplant. Again, the same explanation is here. Now, talking about the same previous question, the sequential one, once the patient recovers from his acute illness, Candida antigen injection into his skin reveals no signs of inflammation after 48 hours. The same test performed in his mother produces 12 mm of his skin induration within 48 hours. which of the following are directly involved in the effector response observed in the mother? So the intradermal injection of Candida antigens triggers a type 4 hypersensitivity reaction, which allows evaluation of cell-mediated immune response. Injected Candida antigens are taken up by cutaneous antigen-presenting cells, which display the antigens on major histocompatibility complex 2 molecules to naive CD4 cells. Now, these cells are then induced to differentiate into type 1 helper cells that secrete the tumor necrosis factor and interferon gamma, which recruit and activate macrophages. Now, these macrophages phagocytose the Candida antigens. Thank you for watching. Keep studying hard.